Hello, this is the training video on documentation. Documentation 101 has been revised in May 2014. My name is Blake Curdell and I'm the Ambulance District Director for Andrew County Ambulance District. And here's our presentation. We're going to talk about the need for complete documentation. We're going to understand the need for proper selection on certain choices on the state form, and definitely stress the need for an important, thorough narrative. We are not in the business of making money, but we do make money to stay in business. This presentation does not cover how to operate the AIM software program. There's an actual slideshow presentation to show you how to use that. There's a separate presentation. So to start off, I thought a lot of ways to start this very important presentation. So I want you to imagine that you are staring at these 12 people. These 12 people are going to decide your fate, or possibly the fate of a person like a drunk driver going to be getting off, and your documentation is what's going to put him away or let him go scot-free. And think about that, especially if he killed a family, a mother and a couple kids. It says you responded for a fall with a head laceration at the nursing home. Why did you feel it was not necessary to place your patient on a backboard? A backboard is pretty standard of care for anything that's trauma related, and especially with something with a head injury. If you don't document why you put on a backboard, you could put yourself in a lot of trouble. It says in your narrative that you checked a blood sugar, but the result is not listed anywhere in your report. I know it's easy to say that this would never happen, but I have read state forms since I've been here that is exactly what happened. It says blood sugar, but not listed anywhere. Did this person have a head injury? What were their pupils like? How much blood loss was there? Is this the way a prudent paramedic assesses their patient? You may have checked their pupils, but if you didn't document it, you know the old adage, if it wasn't documented, it wasn't done. So again, you may have checked the glucose, you may have ruled out the need for spinal immobilization, you may have estimated blood loss or checked the patient's pupils, but at the bottom line, if it was not documented, it was not done. And that's the way I look at it as far as QA. That's the way our medical director is going to look at it. That's the way the legal system, the trauma services, everybody looks at it. Just because you can say, oh, well, of course I did that, it's just understood. It doesn't work that way. I will tell you, a lawyer will have a field day with omissions on a report. It's not what you do that gets you in trouble, it's what you don't document that you did that will get you in trouble. Before we start to talk about narratives, there is not a 100% way to do everything, but the standard is if something is done outside of what a normal paramedic EMT dispatcher with similar training in a similar situation, that's what you should do. That's exactly what you're going to be held as. They're going to bring in, if you go to court, they're going to bring in 5 paramedics that have about the same experience as you, and they're all going to say what the standard of care is. That's what you need to uphold to. Your standard of care and your treatment guidelines. Some things that need to be on reports. Vital signs times 2. I will say, when I was a paramedic working the road every day and writing forms, it annoyed me to have to write 2 sets of vital signs. But you're really supposed to write them every 5 or 15 minutes, and most of our transports take at least 15 minutes. And that's just transport time, much less time you get to the patient. So you're way over the 15 minutes. There's no reason you can't get one when you first assess, which you should, and then get one right before you get to Heartland at least, or whichever hospital you're going to. So at least 2. A GCS should be documented on every patient. If you do it the first time and then there's no changes, fine, but every time the assessment changes with GCS, you need to document that on your form. And again, make sure your GCS is correct. If it says patient is an altered LOC, don't go in there and click 4, 5, 6 on the GCS just to get through it really quick that you're used to doing. Probably some of you are very good at 4 tab, 5 tab, 6 tab, and that'll get you through it really quick. So remember, your documentation needs to be consistent through your report. If you start an IV, document it. You need to put it in your narrative that you started an IV, and then it needs to be in-depth documentation in the chronology section. If you miss, you need to document it. If you don't put your misses, you're actually falsifying a state document. That's not a good thing to be having hold over your head. If you give medicines, put it in both places. Gave albuterol for respiratory distress in your narrative, and then in your chronology section you can put the time, the exact dose, the route, and all that kind of stuff in there. So procedures and need to be in both sections, the narrative and in the procedure section. Patient information. We need patient information. We can't send out bills without patient information. We have to have that face sheet from Heartland. I've taken 3 or 4 patients to Heartland. I've been there a couple more times when other people have taken patients. They get those for you very quickly. Grab them, make sure you don't lose them. We need that information to send to the billing department. If their computers are down or they can't get that information for you, it is your responsibility as crew members to get the patient's full name, their current address, phone number, date of birth, social security number, and obviously gender. If you can get a copy of their medical cards, that's even better, because we have to have exactly what it says on their Medicare card in order to bill Medicare. If it's Nancy Jones, but yet on her Medicare card it says Nancy L. Jones, there's a chance that Medicare will reject it. Then it's going to take us extra time and extra effort to track that down and figure out why. Again, treatment in both areas, very important. We have to see it in the narrative and in detailed. I say it simply: mention it in the narrative, detail it in the chronology section, in the treatment section. The narrative. I've had many classes on narratives. PWW, which is Page, Wolf, something, Worth and Wilbert from South Carolina, I think they are. Anyway, they're the legal law firm that puts all this out. I actually tried to purchase their course, but their course is sold out. I've taken their course several times, and I'm going to give you kind of the gist of it. Narratives are important enough. I wrote a software program just to write narratives, and it's actually on the market called Narrative Pro. So narratives are important to me. Paint the picture. If you've talked to me about narratives, this is what I'm going to tell you. You should be able to read that narrative, and I should know exactly what happened on that call without me being there. Some of my experience is going to kick in, but a lot of times I'll read these narratives and kind of chuckle because, yeah, I've been there. I've been in that situation. But then there's other narratives I read, and I'm like, really? I have no clue what happened on that call. You have to paint that picture. This is Bob Ross, painting his happy little trees. Those of you that are familiar with Bob. I should never, ever look at a state form and say, what was wrong with that patient? I know sometimes Peggy and Connie come to me and say, well, what do I bill on this one? That should never be a problem. It should be so clear that they know what's going on. I'll tell you, any form that's reviewed by Medicare has lay people reading the forms and judging whether that form is justified or not. So you need to write your forms. You can put medical jargon in there if you want to, but you need to also paint at the same time the clear picture of what is going on with that patient, so anybody that reads that narrative, probably including a lawyer, can understand what's going on. And that's exactly what this says. I was just a little ahead of myself. Did you know that our billing staff has to do exactly that on every call? They have to read it and know exactly what's happened. I know Peggy's been through EMT, but neither one of them have had extensive training in reading state forms and knowing what half the medical jargon is. So keep it simple. They need to know what to bill so they can send off and get reimbursement. Remember that you are part of the billing staff too. You can either write a humdinger of a narrative, so clear that no one has to ask you, or you could just write the minimum and try to get by. But I'll tell you, if you write the minimum, I'm going to start bringing you in, and I'm going to say, you need to write an addendum because I have no clue what happened on this call. If I don't know what happened on this call, nobody else is going to know what happened on this call. You're going to write more to that narrative. That's all there is to it. And I'm going to document it, and it's going to be followed up with. So, plain and simply, it is not acceptable to write an incomplete narrative that does not show exactly what was wrong with your patient. It has to be done every call, every time. Hey, I'm ahead of myself again. Not just the potential bad ones, not the ones that say, oh great, this is going to go to court, I better make this one good. No, every time you sit down in front of your narrative, or in front of your computer, you need to write a good, thorough narrative. It doesn't take that much extra time. Tell you a secret, I don't like writing forms. It's one of the parts of the job I really hate. But you know what? In this happy audit patient complaining world we in, sue happy, it's part of the job. It is part of the job. It needs to be done. And I'll tell you, we need to concentrate on those narratives and our documentation. Clear picture every time. I can't stress it enough. When I used to love cooking. I was a cook for several years. I was a banquet cook. I cooked for the Missouri Restaurant Association. I loved it. I'd probably still be doing it if it wasn't for the cleaning. But it was part of the job. It had to be done. Same as the narrative. It has to be done. It is your job for continuity of care. Patient medical records. I'll tell you, every trauma call I send to Heartland pretty much. Uh, Legal lawyers are subpoenaing these reports all the time. You guys don't see it happening. It happens. It happens a couple times a month. I send off reports. It is a quality assurance, which I do, and it's a judge of your medical ability. If I see that your documentation is cruddy, what is that impression going to leave on me as far as what type of patient care you provide? And lastly, we need that for billing purposes. So there's six areas of the narrative that need to be documented. I don't care how you do it right now. I'm not dictating it has to be in this order. But start to finish, it is a lot easier to write and read if you're not jumping around, going back and forth, and just haphazardly writing everything in the report. Uh, we're going to go over each one of these, but it basically, you talk about the scene, you talk about what's going on with the patient, you do an assessment, what treatments you did, any changes you did, and then drop off at the hospital. Scene, this is an important part. This is not being done. What you were dispatched for. Not just other or sick case. It needs to be what the dispatch gave you. Now, hopefully, we're going to be changing the dispatch sheets a little bit. That should be on there. How you responded. We need to know whether you responded emergency, non-emergency, urgent. We need to know those kind of things. What you found when you arrived. How was the patient? How you found the patient. Were they sitting? Were they standing? Were they walking around? Any treatments or anything you did at the scene? And then really important, how you moved that patient to the ambulance. So we talk about dispatch. You need to put what dispatch tells you is the dispatch reason you're responding. They're the ones that know. They're the ones that dispatched you. They know what they're sending you for. When in doubt, look at the dispatch record and it should show you exactly what you're dispatched for. If you're getting something where they're putting something on the report that's not what you're getting as far as seeing, then I need to know about that. But it should be pretty consistent. I don't think this is too big of an issue. Emergency, urgent, non-emergency. Again, lights and sirens. If you respond without lights and sirens, you can still respond emergency. All emergency says is that you responded as quickly as you could to a response that needed a paramedic to check them out, basically, is what it says. So again, the use of lights and sirens does not dictate what the response level is. If it's a bad snowstorm, I'd rather you leave the lights off because people are going to do stupid stuff and they're going to put themselves in the ditch and you're going to cause more problems. The dispatch decision, it's what alert level is dispatched. That's kind of a new thing dispatch is doing. They have a checklist. They only have so many things that they actually dispatch for, and that's what's going to show up on the dispatch list. They dispatch it for what they take the information from the caller. It's the ambulance crew's responsibility to respond in a safe manner. If it's lightning, thunder, storming outside, I don't want you running 90 miles an hour. Be safe. Get to the patient. Alert levels. Alert 1 is life-threatening emergency. Alert 2 is an emergency situation. Alert 3 is an urgent condition. Alert 4 is non-emergency, basically your routines. Returns back. Scene. What was found? The easiest is a 66-year-old female patient. Anything unusual about the patient? Anything about the scene? Any other agencies? Police, fire, road crews, whoever it may be. How they were found. Were they sitting in a chair? Were they on the ground? Were they in a car? Were they crying? Were they clutched their chest? Were they breathing in a tripod position? Anything that needs to be in the narratives. It's crucial. How they moved to the stretcher. Did you lift them? Did they stand and pivot? Did you just can't put, and I used to be really bad about this, assisted to ambulance stretcher. We need to know, stood and pivoted, lifted up, moved ambulance stretcher without assistance, whatever it may be. An example, I'll just let you read this really quick. I think it definitely tells you a clear picture of what you were dispatched for, how you responded, what you found, and putting that patient on the stretcher. History, present illness. How long has this been happening? Have they ever done this before? Have they had any, what did they do? What did they treat? Did they take breathing treatments? Did they take nitro? Did they take aspirin? Any other complaints? Here's a quick example. Again, telling you exactly how long it's been going on, what started it, what they've done, any changes, blah blah blah, right there. Assessment. You need an assessment in your narrative. Do not be surprised if the assessment section where you do the check boxes gets turned off on the AIMS system. You have to write an assessment on every patient in there, and not just consultation oriented, no complaints. There needs to be some more information there. If they're in pain, the OPQRST, AVPU, what's their level of orientation? And again, level of orientation should match what you put on the GCS, and it's also going to match your signature forms. If you put conscious, alert, and oriented times 4 here with a GCS of 4, 5, 6 of 15, and then on your report, because you forgot to get the patient to sign, you say altered level of consciousness, that's not going to set. Skin color, temperature, moisture, pupils, anything wrong with their head, neck, JVD, anything like that, lung sounds, chest, injuries, EKG, abdomen, pelvis, genitourinary, pedal pulses, swelling, edema. Again, same with the arms, swelling, edema, pulses, movement sensation, any complaints they have, any other assessments like the SaO2, the end-tidal CO2, 12 leads blood glucose with a value, temperature, any other assessments that are pertinent. Pertinent negatives. Pertinent negatives are crucial. Just because you don't find something, sometimes that's important, especially when you do like a Cincinnati stroke scale. Pertinent negatives are pertinent. That's why they're called that. Here's an assessment, patient conscious, alert, and oriented to person, place, and time. Notice I didn't just put CAO times 4, only because if a lawyer ever gets a hold of it, they're going to have a field day with you. Skin, pink, warm, dry, within normal limits, pupil equal, round, reactive, and so on. Pretty clear. You can always pause the presentation if you want to read all the way through that. Treatment should be detailed in the report. I think I've stressed this enough. And you need to document it in your narrative under the treatment section of what you did, or somewhere in your narrative. Again, it doesn't say, maybe probably could have put place oxygen via nasal cannula, baby aspirin, encouraged to relax, transport in semi-Fowler's position. No IV, not listed in the treatment section. This is probably something that's going to jump out at me. Hey, there's no IV here. There may be a reason you didn't start an IV. I'm not a big proponent of starting IVs just to start IVs. Uh, saline flush is $2. IV thing is $2, and a catheter's $4 or six. It's about six to $7 for just an IV setup. If it doesn't need it, they don't need it. I mean, I'll support you with Heartland staff yelling at you because you don't bring a patient in an IV. I do not start IVs for nurses because they want it. I just don't need to do that. We don't need to do it. There are over 600,000 pre-hospital needle sticks. That's providers getting stuck with needles every year. So if you get stuck with a needle and it wasn't a necessary IV, that's just a needle stick you didn't need to get. Again, place patient on oxygen. Did not attempt IV due to patient having underskin access port as requested by the ER to access upon arrival. Ongoing, just what you did on the way to the hospital. Any changes, document contacting the receiving hospital. If it is a stroke alert or a STEMI alert or alert level 1, please note that in your reports. I'm having a lot of troubles with the ER asking. That's the first question the ER asked me, or the stroke people asked me, or the STEMI people. Well, did they call this in as a stroke alert or whatever? That needs to be documented if you did. Okay, pretty simple there. Destination, last step is to the ER, moving the patient over. Make sure you show how you moved them over, who you gave your report to, the patient's conditions, any valuables left with the nurse, and in unit available time, or just unit available. And this kind of gives you a quick. I do have. Never mind. No two people write the exact same narrative. I don't care what methods you use for your narratives, but after you were done with your narrative, ask yourself 2 questions. Did I get the required areas covered in the report? I have a handout sheet that you can download that lists the general narrative suggestions and what needs to be in your narrative. So I'm giving you all the tools that you need to make your narratives thorough and clear. And then the second is, which type of picture did I paint? Did I paint the one that Bob Ross painted on the left? Or did I paint the one that I believe one of my kids colored? You can be the best medic EMT in the world and provide the best patient perfect care, but you don't know how to write your narrative, and that is the way you'll remember it in black and white for years to come. 5 years from now, you're going to be sitting on the stand. They're going to make you look like an idiot if you do not have a clear, concise narrative that says exactly what needs to be said. What do you want your narratives to say about you? Returns, you think they'd be the easiest, the least to document, is probably the hardest to document for Medicare. There's a few specific things that need to be answered on every time. Non-ambulatory, unable to get out of bed, unable to ambulate, unable to sit in a wheelchair. It is once described, if a house is on fire and a person could get on their own, they are probably not non-ambulatory. It needs to be documented on returns why they are not just non-ambulatory, but why. They're not ambulatory due to severe muscle atrophy. They are not ambulatory due to left-sided stroke and unable to get out of bed. Well, something like that. So the actual reason why has to be documented. Transfer from hospital to hospital. We don't do a lot of these, but a few. Transferring diagnosis, the exact service, procedure, or specialist that they are transferring to see. If they're going to see a neonatologist, that's what needs to be in there, not transferring for higher care. It needs to be specific. Heartland can't do this procedure for their machines are broken, whatever it may be. It needs to be documented what the exact is. Some random other thoughts. Drop down boxes. Most of them fill in on their own, but there's some that people just want to fill in and say not applicable even when they don't need to. Incident types is a big thing. It needs to be selected initially, And these are the ones that you can choose from. There's actually a list out there that is this exact list. It's pretty self-explanatory. The thing I will point out is under the treated and transported right here, the EX is emergency ALS. Paramedics will use this one for scene responses. Treated, transported by EMS, BLS. Only when EMTs are going to work the call. Treated non-emergency ALS. Paramedic works a trip that does not require any services for the paramedic. You can use this one. And in non-emergency BLS, this is what you'll use on your returns. Do not use canceled out of primary service area, cancel prior to dispatch, cancel request, and then other not stated reported, and then these two. There's no reason to use any of these. They don't mean anything. I can't get rid of them due to programming through AIM, but we just don't need to use them. Dispatch has a list of reasons why they use in their alert levels. It's a colorful paper. It should be on the dispatch sheet to be able to tell you what they're dispatching as. Crew details is a big issue on a lot of forms for some reason. You need to select a role for each crew member. So it's going to say Blake Riddell, primary patient giver, Blake Riddell, driver. Those things, those roles need to be selected. That's not being done a lot. Also, as far as if they're a paramedic or an EMT, somebody reading your form 5 years from now, after you're long gone, won't know if Blake Riddell was a paramedic or an EMT or what he was. So that needs to be documented too on the crew details area. Situation chief complaint should match somewhat to the primary impression and the primary symptom, same as the secondaries. So if their chief complaint is weakness, you type in weakness, and then you go over in their provider, you select abdominal pain. Those probably need to match, or at least document why they don't match or why you didn't feel they would match. Times, I actually wish I had a picture of this, but in the chief complaint, underneath it, it'll say unit, it'll say time and then units. Time 2 and then units would be dropped down for hours. If you do not put anything in the time slot, do not put anything in the units slot. So don't put nothing in time and then put not applicable, because that'll reject through the state of Missouri. So just leave them both blank if you don't know what to put. In the supplemental section is where the dispatcher goes. The dispatcher does not go into the crew roles area. They go in the supplemental area in the very last tab. Again, dispatch complaint. What we are dispatched for may not be what we actually find. We need to document all three. We need to document what we were dispatched for, an ALS assessment was performed, and then what the true reason for the ambulance was needed. If we get paged out for chest pain, and you respond emergency as quickly as you can, and you get there and you perform an ALS assessment, and you find out, this patient's only probably got pleurisy, and it's not something I'm going to start an IV for and take to the and do anything on the way to the hospital. I'm just going to babysit him to the hospital. We can still bill at an ALS level for that because we responded emergency and did an ALS assessment. And Medicare actually pays you for being prepared and kind of helps out services that don't find what they thought they were going to find when they got there. So those all need to be documented. There are certain fields that are mandatory, there's others that are optional. If you need to fill in more of those optional ones, you're more than welcome to paint the picture. Is whatever you need to paint your picture. Don't forget the all-important WDKWTM acronym, which stands as we don't know what that means. WNL is that within normal limits or we never looked. It's kind of a joke there anyway, but LOC is level of consciousness or loss of consciousness. So be very careful when you're using acronyms or abbreviations that those are standard. Make sure you have some backing to that. If somebody says, well, why is that an abbreviation, or where have you seen that, you probably should have a reason and not just be making up your own. That's exactly what this says. I know the report stuff is boring. I know you've heard it a lot from me. You're probably going to hear more. We need to get our documentation a little bit tighter here. I am asking that everybody write the best narrative possible. I know it's not one of the highlights of the business, it's not the exciting, flashy part, but it needs to be done nonetheless and done correctly. I've tried to give clear guidance on how this should be done. I put this presentation out earlier in a little after January. I know we talked about it in January. I put a PowerPoint presentation out. I'm doing training videos. Everybody should have the tools that they need to be making these narratives the best they can. And again, which picture do you want to represent your body of work as an EMT or a paramedic? You know, it's nice that those people are going to have the memories, but the narrative, the report, what you do in your documentation are what's going to stand the test of time to say, this is me. Do I want the one on the right to be the pictures that I paint, or the reports that I do, or the one on the left? There is a mandatory online test for this presentation. There's no CEUs. It's called Documentation 101 Revised May 2014. It's 100% passing, so keep taking it until you get it done, and it's found at classmarker.com. If you don't have your login or know your login, come see me, and I'll be more than happy to give it to you. I appreciate it. Thank you very much.